Hello, everybody. I'm going to share my slides. And while I'm just doing that, Rebecca, do you want to introduce yourself first?
Yeah, hi, absolutely. Good afternoon, everybody. My name is Rebecca Stone. I am a counsellor and the older adults lead for Bradford District and Craven Talking Therapies.
Right, let's play from the start. Thank you, Rebecca. So I can't see anybody now except Rebecca. So she's going to be my anchor in case she sees anything coming up in the chat. What we're planning to do is talk for probably 25, 30 minutes. We're flexible. And then what we'll do is answer questions and hope that it'll be a bit interactive. And so we'll probably rattle through this bit and then come up to questions afterwards. So I'm Dr. Sarah Humphrey. I'm a GP with an extended role in older people and the Associate Clinical Director covering frailty, learning disabilities and dementia for Bradford Health and Care Partnership. And I'm also heavily involved in research at Bradford University. What I'm hoping to talk about today is recognising depression in older people, but I'm going to focus a bit on the things that I think are different to working age adults. And I think most people on the call will be working age adults. So the first thing to talk about is this thing called the biopsychosocial model of disease. And this is the interplay between three really important parts of our lives that is particularly important when we think about in depression for older people. So when we talk about the bio, here we're talking about disease and symptoms and doctors and treatments and science and tests. So that physical part of our health. The social thing are those hobbies and families, careers, friends, money, isolation. So that social bit of our life. And psycho is the way we feel. So that's the depression, that's guilt, that's anxiety, that's our stress. That's the tears. These three things all interplay in older people. So they're all important and each one affects the other. So I really like this statement that's at the bottom of the slide. And it says, the medical support keeps me alive, but it's the psychological and social support that enables me to live. So they're really important, all three of them, in managing illness. The next thing that I'm going to tell you is that older people don't always talk the same language as working age adults. And psychological distress can come across as all sorts of different words. And that's important when I take you through why we don't recognise it. So things like hopelessness, confused, worthless, insecure, uncertain, unfocused, lonely can all be words that describe psychological distress. So they don't always come up to you and say, I'm depressed. And that's important because we're poor at recognising it. So often, and we haven't talked about it today because we just didn't have enough time, but often when I give this talk and when Rebecca and I were talking, anxiety is a really big thing as well. And again, it's a really big interplay, but we didn't have time today. So maybe another lunch and learn session. So why are we concerned about depression? Well, depression is the most common mental health problem for all ages. Up to 2.4 million older people will have symptoms of depression, which is severe enough to impair their quality of life. 2/3 of older people with depression don't raise it with their GP. And of the third that do, only a half are diagnosed and receive treatment. So that means the other half, somehow, even if they mention it, and I'll talk about this later, they don't get the treatment they should do. Depression, and I've got another slide on this, increases the risk of physical illness, abuse, and suicide. So it's important. There are risk factors for older people for developing depression. And when you look through this list, actually you'll see and recognise a lot of these coexist in a lot of people that we will see within health, social and third sector services. So the risk factors include physical illness, such as pain, heart attacks, strokes, cancer, Parkinson's, loss of vision or hearing, dementia, excessive alcohol use, Bereavement, very common in older people will have experienced a bereavement, being a carer. That loss of independence, home and social networks, loneliness, any past history of deprivation and abuse in their own childhood, so previous traumas, and a previous history of depression. So almost we know that you've got an increased risk if you've already experienced that in previous life, and certain drug prescriptions as well. So those are the risk factors. Another lovely way of thinking about it, and this comes, and I'll show you the slide later, from a wonderful slide by Alistair Burns, and it's just a way of thinking of the risk factors. So the first is A for alone, B for being bereaved, C for being a carer, D for drinking, and we're not talking tea, E for people who talk about low energy, all right, and being tired, F for frailty and physical illness, and G for general reaction. Now, what I mean by that is sometimes we have this thing called counter-transference. Those people who make you feel really frustrated, all right, as a clinician, think about, could they be depressed? Why do we miss it? Well, there are factors within the older people themselves, and then factors when as staff, I'm talking about all of us professionals. So within older people, there is definitely a stigma to reporting mental ill health, much more of a stigma than for younger people. We seem to have overcome that somewhat. They may not be able to express it, so they don't always have the language, or are able to if they have things like depression, dementia, or had a stroke or something. They may express it as bodily symptoms. We'll talk a bit more about that later. So they talk about it being physical. Okay. Again, with that stigma, people often feel ashamed. They often would say, you know, I have all of this, and why should I be? And the other thing is they don't use the word depression. So those all come together in the person coming towards you and seeing you in a clinic or in any setting. That's going on, and that's why they don't present with we don't see it in them. We then have us as staff, and we don't consider it. And because we don't consider it, our recognition is low. We often believe it's justified or normal. Well, wouldn't you feel depressed if you never left the house? Almost as if that means that we can't change it, because we can't change the getting out bit. We can't change the depression. We often feel ill-equipped to deal with distress. Supporting somebody with distress raises those emotions in ourselves, and some people, you know, it's a lot easier to keep that can on the lid of worms than take it off, because actually that's really hard. Those prescribing clinicians among us worry about side effects, and absolutely older people will be affected by the medications we prescribe, but that doesn't mean that we can't have a go. Okay. And then lastly, we often believe it's untreatable, and when Rebecca does her bit, she's going to absolutely show you that's not the case. So I've already given you a bit of a picture about the differences in presentation between older and younger adults. And this is just a bit more information about that. They often will talk about the anxiety rather than mood. They may be restless or agitated, pacing and irritable. People might report, family might report personality changes, but not always might use the word depressed to describe that personality change, okay? They may be very preoccupied with physical symptoms, faintness, dizziness, pain, weakness, constipation, tiredness. So that becomes the overwhelming bit of their presentation, the thing that they will present with that they feel most bothered about. They may present with an unexplained functional decline, okay, walking and incontinence. Now, obviously, what we don't want people to do is ignore the physical side of things. But what I want you to do is think about, when you're doing that, where does could depression play a part? They may present with memory problems, And they may have denial or minimalisation of depression as a cause. They don't want it to be that. So all this combines again in the different presentations. I'm going to go into a few more factoids in a moment, and we talked about the risks associated with depression in older adults. But it just helps, I think it helps you to know a bit more to why it's so important. There is actually an increased mortality, death rates in people, older people with depression, especially from what we call cardiovascular causes, the heart attacks, the strokes. They're more likely to self-neglect and neglect their other physical illnesses, which becomes a bit of a self-fulfilling prophecy back into them managing, them being able to manage those and then get more depressed. There's an increased risk of suicide. There is a risk of increasing cognitive impairment because you have depression. And finally, there's an increased risk of institutionalisation, and we're talking going into care homes and things. So if you like numbers and facts, here are a few numbers, a few factoids that might, again, help you to put it into context. Maybe when you're talking to other people, it's 7 times more likely as depression if you have 2 or more long-term physical conditions, which a lot of older people do. A diagnosis of depression in those aged over 65 increases your subsequent mortality, that's your death rate, by 70%. And it's associated with a 50% increase, even if you look for what we call confounders. So let's say smoking or diabetes. So if you take away those, you've still got a 50% increased risk of mortality. And that's comparable with smoking. And just think how often we talk about smoking to people when we see them in clinics. It doubles your risk of heart disease, ischemic heart disease, that's your heart attacks, 11 times increased risk of stroke. It reduces your physical activity, which then leads to poor muscle tone, which then means you're more likely to fall and more likely to break your hip, which then increases your risk of getting depression. It actually reduces your long-term compliance with medications, and that means that your diabetes or other long-term conditions are negatively affected. So you can see that's a bit of a bleak picture, isn't it? How often will you see depression? Well, prevalence is, if you were to look at 1,000 people in the community living there in the community, and think about those 1,000 people out there, just in everybody, they're not people who come to the doctors or anything else, about between 3 and 15% of them will have depression. It's quite a lot, isn't it? 15% of 1,000 people. A few more, 15 to 20% in GP surgeries, similar amounts in care homes will have depression. If you get into an acute hospital because you've been ill, that can go up between 20 to 40%. And it's more common in women than men. So you can see it's pretty prevalent, really. So what is it? I put this in because, sometimes you just need to be reminded of the definition so that you can then think about how you're going to ask the question. So we probably know the symptoms and signs. We know it's probably one of the most commonly known mental health illnesses that people will probably identify with depression. And these symptoms should be on most, or at least most days for at least 2 weeks, causing significant social or functional impact. They must affect you in some way. It is not a normal experience. People often talk about, well, I'm a bit depressed, but it's not a normal experience. It is not an inevitable part of aging, so you shouldn't ignore it. This is a quote from somebody: "I feel I am treated differently because of my age. It feels like I'm invisible now, and I think sometimes I don't get offered services because I'm old." And actually, that's true for older people. Sad to say, older people's mental illness is often ignored. How do you know if it's depression? So, what might you know about how you feel? Well, you might feel low. You might feel worthless, hopeless, isolated, bad things might happen to you. You might feel tired. You might have no pleasure in stuff that you used to do. And that leads into things like worrying a lot, avoiding social stuff, so just not wanting to go out anymore, constantly worrying about your health, having difficulty thinking clearly, speaking clearly, and making decisions. You're just stunned into an activity, unable to relax. And some people eat and sleep more, but some people eat and sleep less. And the changes that you would see within your body are more aches and pains with no obvious cause. Some people slow down or become restless and agitated. Things like pins and needles, fast breathing, feeling dizzy or sickly, sweating, hot flushes, and some people will have panic attacks. This slide is about assessment. So this is basically what would happen to you if you were an older person and you came into a GP setting, what we call primary care. This is what we would do. This is what you can tell people that they're going to experience. Well, firstly, we talk about history taking. That basically means talking to you about what's happening. We try and get a clear picture of what's happening. We may look for signs of what we call risk. Are you at risk of self-harm, neglecting yourself, or having suicidal thoughts? And asking that is really important. Collateral history is when somebody comes with you and when we ask them about things that you may not be able to say clearly, so how it affects you. We will probably rule out some physical health stuff and look at medication. We will ask a couple of screening questions, and then we may use an assessment tool, and I'll show you a couple, and there's quite a few out there. Assessment tools will give you a number out of, let's say, 10, might be a different number, and they will tell us how bad it is, all right? And that they're useful to be able to give you a bit of an idea of how bad it is at the beginning, but also whether you are responding to treatment or not. And they help in our decision making. So the two screening questions are from NICE. And what we ask: in the past month, have you been troubled by feeling down, depressed or hopeless? And have you experienced little interest or pleasure in doing things? And actually, if you say yes to both of those in the last month, we would go on and do some more in-depth questioning, because that increases your risk of having depression. That's just one screening tool. I'm not going through it, but what you can see is we ask quite a few questions about some of those symptoms we talked about. Things like memory, do you feeling hopeless? Are you bored? Do you feel life feeling empty? And we use that to come up with a bit of a score, okay? And that helps us to firm up whether we think this is definitely depression or not. And then this brings me to this slide that I was telling you about from Professor Alistair Burns. And what he's done in one slide is put your risk factors that we talked about. He's put your screening questions. He's talked about, he used the geriatric depression scale, but it could be others. And then what he's done is put a treatment pathway. For some people, just coming to talk to the GP, just acknowledging that this might happen, and scores are relatively low, we might, what we do call watchful waiting. We might come back and see you in a month and see how things are going. If we think depression is likely, but your scores are relatively low, now this slide is old because it talks about IAPT, and now we're talking about talking therapies, but we might refer you for talking therapies. If scores are higher, we might think about medication. If scores are higher and we're seeing those risk factors, self-harm, self-neglect, significant weight loss, or people having suicidal thoughts, we might refer in urgently or semi-urgently into specialist services because we need extra support. So that's the sort of on a slide treatment of depression in older people. So what happens once you get diagnosed? Well, course and prognosis, and I looked at this slide afterwards and I nearly took it out because it all sounds a bit bleak, but it's not that bleak, but you have to, but people want to know, and it's worth you knowing that so that you can better describe and support people. So the average length of depression is, of disorder is about 6 months, but over 25% will go on over a year. So I always talk about 6 months to a year. Give them it's not a quickly solved thing, okay? About 10 to 20% will get a chronic depression, and 80% of people with a major depression will get further episodes, and that can be up to 5 further episodes, and a third will not go into remission between episodes. Okay, so that's makes it even more important that we don't leave it unrecognised to go on. Okay. The management. That goes back to that slide that I showed you. Okay. We look for biological things that we can make better, improving pain, looking at medication. We look at psychological stuff like supporting relationships, helping carers, getting carers supporting. Look at your social factors like isolation and lack of stimulation. Those can help. Think about talking therapies, and Rebecca will talk to you about all of those. Think about medication, okay? And remember what I said to you, that people don't get medication when they should because we're worried about side effects, but they can be really helpful. And we have our old age psychiatry colleagues if people don't respond or it's a severe depression with risk factors. So I'm now going to pass over to Rebecca, and Rebecca's going to do her bit, but I'm going to be her Chris Whitty. So you may hear it if I'm not good at moving the slides on, going next. And for that, we apologise. So over to you, Rebecca.
Thank you so much, Sarah. So as you know, we've had a little look there about sort of recognising depression, what that might look like, and some sort of more medicalised treatments. So I'm going to be having a little chat today about depression in older adults, the prevention, simple self-help measures, the talking therapies, other organisations and resources. And as mentioned here, I am a counsellor at Bradford District Care Trust, but I'm also the older adults lead. Next slide, please. So when we're thinking about preventing depression in older adults, as Sarah mentioned earlier, it's addressing any physical health issues early, because obviously they can kind of go hand in hand together. Offering that person-centred treatment, again, obviously we need to be aware of the person's age, but also thinking about it from a person-centred point of view and thinking about their needs. Identifying any sensory impairments and manage those well. Having time to listen to life stories, find time to sit and chat with people, because that can be really important. We can often find that older adults can be quite isolated, and those appointments with specialists, with people within the community, it might be the only time they've had a chat that week. So just really finding time, which I know can be difficult. Listen and share and give genuine time and take an interest, and work on building that therapeutic relationship. We'd like to encourage activities which are enjoyable, and again, it's making sure that they're achievable as well and manageable for somebody, and that it's okay for them with their physical health. Encouraging exercise, identifying depressive symptoms early. So again, we want to kind of get in there really quickly rather than it becoming something that's much more severe. And again, signposting for local support and social groups can have a huge impact on people's well-being. So when we think about well-being and how we can prevent, I really think this is a really lovely little image. And we imagine a table with the 4 legs, and there's these 4 parts that are really important: diet, sleep, exercise, relaxation. And what we need to remember is it's important that we aim to keep these legs in balance with each other. And actually, if one's a little bit off, it can make everything else just a little bit wobbly. So it shows how the mental and physical health can impact each other, and if one leg is out of balance, how it can affect us mentally and physically. So it's about the mental health and the physical health coming together. Next slide, please. So just some really simple self-help measures that can be just, again, helpful to share with anybody that you're working with. And one of the most important things, I think, is compassion. To be kind to yourself. It's important to have a treat from time to time and do the things that make you laugh and have fun, particularly for people who are maybe struggling with physical health problems and maybe feeling isolated. It can be really important to help them find time for things that they enjoy. Getting enough sleep, and of course, as we know, sleep patterns can change as we get older, and lack of sleep can directly affect the way we feel. Eating well and drinking sensibly. So what we eat and drink affects how we feel. So try not to fill up on the wrong things, but also don't try to ignore the signs that you might not be eating enough, such as losing weight unexpectedly. Keeping active, as well as keeping yourself healthy. Exercise is a great way to improve your mood as it increases the production of endorphins. And of course, creating structure to your day, having that routine and setting yourself goals. So most of us look forward to retirement and having time for ourselves, but when it comes, it can be hard to adjust. to the loss, structure of our lives, purpose of the working life gave us. So setting goals, making plans, and gives our lives meaning and purpose. And so just starting small and making sure that you're realistic. For example, you could set yourself a goal to go for a 10-minute walk every day. But again, it's making sure that that fits in well with the person who we're working with. And I wanted to share another really great image. And we use this a lot in the therapy that we offer. And it's a great thing called the stress bucket model. And what we recognise is that obviously life happens, relationships, financial problems, nutrition, work stress. Obviously, they may be retired, but they might still have the stresses. There might be volunteering, there might be responsibilities that they still have. And what can often happen is that the bucket can overflow. So the results can obviously be injury, depression, getting poorly, or having a mental breakdown. And so the aim is to use that tap there, where what we wanted to do is let some of that out. So that might be yoga, meditation, rest, relaxation, therapy, laughing with friends, exercise, healthy eating, and sleep. So again, just being aware of what comes in, how can we let some of that out? Next slide, please. So a little bit about our service. NHS Talking Therapies is a Bradford District NHS Foundation Trust service offering a standalone psychological therapy for 16 plus across Bradford, Airedale, Wharfdale and Craven localities. So our service is part of the National NHS Talking Therapies for Anxiety Depression programme, which you may know as IAPT. It was developed to improve the delivery and access to NHS psychological therapies for depression and anxiety disorders. And NHS Talking Therapies aim to improve early access to psychological interventions for common, mild to moderate mental health problems. So what Sarah was saying earlier on about it's really important to get in there, ask those questions, have that really open, early conversation before it gets to the stage where maybe things are a lot more severe and they need more intensive treatment. Next slide, please. So something that the reason I became the older adults lead and kind of really, we have a SIG group, special interest group in our service, because what we recognise is that we simply, not just our service, but services nationally are not getting the number of older adults coming in for therapy. The national expectation is 12% of our entire people coming into our service. There should be 65 plus. And the majority of talking therapy services are simply not reaching that. So what we kind of recognised is that something's missing, because we can see from all the numbers that older adults struggle with mental health, they can struggle with depression, they can struggle with anxiety. But what's happening? Why are they not getting in for treatment with ourselves? So many older people actually express a preference for talking treatment, and that there's really, really good evidence for the effectiveness of psychosocial interventions such as psychoeducation, CBT, behavioural activation and counselling. And actually another thing that was really shocking for me is that people are it's not being seen, as Sarah said earlier on, it's not being seen, it's not being recognised, and when it is, they're not always being referred or signposted to our service. And actually what it really shows is recovery rates for older people who access these services are much better for those reported for those under 65. So actually an older adult over 65 is going to usually have a much better outcome from therapy than their younger counterparts. And studies have shown that older people prefer talking therapies. Studies show that older people prefer talking therapies, and it's actually classed as more acceptable than medication. And finally, older people often do not ask for mental health support, but they do. When they do, they're more likely to be prescribed medication rather than psychological therapies. So again, it's just we know that they can really benefit from the therapy, but it's encouraging them to come to us and get that support. Next slide, please. So some of the things that we've been doing as a service specifically, but I think this is not just us, I think a lot of services out there now are really working on improving access and treatment. Some of the things we've been doing is liaising with GPs, adult social care, district nurses, voluntary sectors to improve pathways. So letting people know that we're there. One thing that's been really a big part of my role is improving our marketing. So one thing that was really interesting was a study about how older adults react to language used with mental health. And there can be a real stigma, as mentioned earlier, about the use of the words depression, anxiety. And so we've been using images of people who look happy and are smiling and looking hopeful, and that's actually shown really positive responses from older adults. And we're using language such as want to feel brighter, want to feel more you, be kind to your mind, rather than depression and anxiety. We've also been using feedback from older adults who've been accessing our service to understand what we're doing well and what can be improved. We've been piloting in-house workshops because, as mentioned earlier, those who are in maybe care home, sheltered accommodation are more likely to struggle with their mental health. So we've been doing some in-house workshops, assessments, etc. And also we've been doing some specific training for clinicians to improve that knowledge and skills and their confidence in treating older adults. As mentioned earlier, we've got a special interest group as well, which is fantastic. And finally, we are working really hard to meet the older adults positive practice guide recommendations. So that's what we're doing as a service. There's just some really lovely feedback that we had from when we did the questionnaire. Joan said, give it a whirl because you may just find the answer. Bilal said, just do it, grab it, do it. It's so worthwhile. I found it really positive. And Jack said, I started to really look forward to speaking to her. It's helped me come through at a really low time. So not only are we getting out there and seeing people, they are having really fantastic responses and changing their lives, which is wonderful. Next slide, please. So what do we offer in our service? So we are a primary care service. We offer treatment for mild to moderate depression and anxiety, and our service is comprised of 2 steps. The treatment pathway is always agreed at assessment, but we offer step 2, which is low intensity or guided self-help. That's face-to-face 6-week course for older adults to help manage stress and well-being. And we've actually done a specific older adults course to make it more appropriate for their needs. We can offer one-to-one sessions with a psychological wellbeing practitioner and also computerized CBT. And even though we might not be pushing that as much, we also can't assume that older adults are not computer savvy. Higher intensity therapy, counselling for depression, which is what I do, CBT, EMDR, and trauma-focused CBT. So these are some of the treatments that we can offer older adults and anybody of any age. Next slide, please. So how do you access us? Well, we do encourage self-referral. Again, it just puts that onus on the client, but of course we would also encourage, if they don't feel able to do that, to support them with the referral, and here's details on how. And of course you can put a professional referral through as well. We will have an assessment, and then of course we will put them forward to the most appropriate course of treatment. Next slide, please. Here's some just general contact information. Follow us online as well. We've also got our social media presence. But yeah, as you can see there, it's from IAPT to NHS Talking Therapies. So that's just so you know, that's our new name, and that's a new completely national change. Next slide, please. Just very briefly, we are not a crisis service. So we obviously, and again, this will be always assessed during the assessment, but anybody who is very risky, obviously we will not be able to work with. It's unlikely. And of course, we would encourage them to contact the crisis services for support. Next slide, please. Finally, there's just a really lovely video. I won't share it with you today because of the time, but it's a fantastic video about older adults with mental health. And just an easy access website for you to look at, which is full of really good advice. Next slide, please. Finally, these are just some organisations that I often signpost clients to. You may have heard of some of them, particularly Age UK, for example, is obviously a really big one. Bradford Senior Power as well, fantastic. U3A again, so just knowing that there's lots of services out there for older adults. And thank you for listening to both of us. Does anybody have any questions?
Right, I'm going to stop sharing. So are there anybody brave enough to ask a question or just make a comment on from what you've heard of your experience of if you support people, signpost people? Anybody brave enough to say something? Jacinta, first hand up, far away. Oh, I think you might, are you on mute?
No. Can you hear me?
No. Right.
Can hear you now. Yeah.
Oh, can you hear me now?
Yeah.
Oh, right. Okay. Gosh, I wonder what happened there. I was just wondering, you were saying about how older people find it difficult to express how they're feeling in terms of, we might use depression or anxiety or whatever. And I think obviously as time goes on and our generation becomes older, it'll probably become easier in terms of expressing what's going on. But why do you think that older people aren't able to articulate it in the same way that maybe we are? Do you think it's a generational thing?
Yeah.
Yeah. Sorry, Sarah, go on.
You go on first, Rebecca, and then I'll tell you my perspective.
Yeah, absolutely. I think that is one of the biggest challenges actually for older adults. Having, particularly, I work in emotion focused therapy, so again, that can be a really completely new way of being. It's like learning a new language for a lot of older people. But yeah, I think we, and again, it's an assumption, but I think there's that kind of coming from that stiff upper lip kind of, keep calm, carry on, push things down. There are people much worse than I am. So again, for me, it's always just about really sort of normalizing emotions, some education about emotions and what they're offering and what they're helping us to understand. But yeah, I think a lot of it is a completely new language for a lot of people. That's been my experience.
Yeah, I agree. And I think you have to remember that people who are older may have been through very traumatic times that we haven't as working age adults. And one way, or it was one way of coping, and actually sometimes feel guilty that they may have low mood symptoms now when they almost think, well, I don't have any reason to feel depressed. They think about the war and traumatic times of deprivation in the past, and we'll think, well, I've got relatively affluent life, I have a lot more than my parents had, the world is relatively stable, and so feel guilty that they should feel like that, as if it's a choice, and that adds to the stigma. So it does feel different to younger people, and I don't get many people coming in with that opener, whereas that opener is relatively common with younger people. They will come in and the first thing they will say is, I'm feeling really low or anxious or depressed. They will use the language that tells you what's wrong, whereas older people come in with something else. They talk about the physical thing, and then you all get involved in that. So not colluding quite, because that's sort of the wrong word, but you get overly focused on that. And so everybody sort of doesn't think about depression. And I don't think they realise that what can work as well. They don't see that, if you've got a long-term physical condition and you don't see that's ever going to change, then you may not realise that actually the way you feel about that and the mood side of it can actually improve, even if the long-term condition like your stroke. So stroke is a relative, depression post-stroke is quite common. And so people don't realise actually you can actually get better from that element, even if the stroke stays the same. Sorry, I was a bit long-winded, Jacinta.
No, that's fine.
So, Sasha, did you want to come in?
It was just, I thought it was a really fascinating question, because there's something about language and exactly how you've both kind of described how people use that differently or not find the words or describe something differently. But I don't know if there's something about also, even when you do know the language, you don't think that's what's happening to you, because either it's because of the stigma that surrounds mental health and depression, anxiety, and those words. So you don't then want to use those words, even if that is, or you don't have that language. And so the only way that you can describe what's going through is then thinking about the physical symptoms. And again, the less stigma there is about talking about your physical symptoms, and that happening. So I just thought that was really fascinating, both kind of what your reflections were, but just kind of what we hear when we talk to groups that don't speak English. So, in Bradford, we've got 150 languages spoken. So many different ways of people expressing and what happens in different cultures about what knowledge there is about depression and anxiety playing a role, but also just how we start to have those conversations in different ways, and do that. The question I wanted to ask was, and it's slightly related to culture, but also age. Something that definitely that came to light, and I learned through COVID. And when I look back at kind of working in operational services, definitely something I'd witnessed is people who have a trauma history, who maybe from different cultures, but definitely the trauma history being the factor, often show some of the kind of indices that you talked about older people a lot younger. So actually they are working age adults still, but very much showing kind of those signs. And it's kind of wanted to hear your reflections on that, because I think I've become more and more struck by that.
So Rebecca, I don't know if do you see younger aged people, or are you? Yeah, you do. Okay, so do you start with answering Sasha's question, if you feel able to, and I'll come in just with my thoughts.
Sorry, Sasha, could you repeat what you said there? I was having some technical problems. I couldn't hear you clearly.
Yeah, my internet's not great. I'm sorry. It was just about some of the things that you might see in older people, particularly around their mood, and whether that age is a factor in that. Because, like I said, what I'd seen is that people who have a trauma history often show some of the other kind of aspects of frailty and other things at a much younger age, and how that impacts on their emotional health. So just kind of your reflections on whether you do see that in practice.
Yeah, absolutely. I think that there's definitely a difference for me in the working age adult and the older adult. And I think there's something, isn't there, as well, about the older adult term. You know, we use that term in our services, 65 plus. I mean, we have people on our waiting list now or in therapy who are in their late 80s. So again, we're really aware of this huge difference in cohorts, the different cohorts within a cohort, if that makes sense. So yeah, I think that for me, it's about doing my best to remain person-centered. Yes, being aware of the client's age, because it's very important. Their generation is very important. Their cohort is very important. But for me, I always try to put past all of that and see the person, see their needs. Regarding obviously physical frailties, of course, we will make adaptations if needs be. We will obviously make sessions can be longer if necessary. But essentially for me, it's about seeing the person that's sat in front of me and always putting their physical symptoms and their physicality, their age to one side. I don't know if that makes sense. I'm working with the person rather than their age or...
So Sasha,
I don't know if that makes sense.
Yeah, I think it makes sense.
Yeah.
So Sasha, for me, when people talk about frailty in older people, they're talking about basically a vulnerability from loads of things that are going on with them. And I do think trauma creates part of that vulnerability. Now, frailty is a term we use for older people, but I do think that trauma is part of that vulnerability profile for all age groups, and actually makes you more vulnerable to either experiencing mental health issues, but then there is something about, if a trauma was quite severe, it goes back again to that stigma about, well, I've survived a trauma, not always connecting it with a previous trauma. And it's trauma that basically hasn't been resolved, or mentally you haven't managed to resolve some of that or recover fully from it. So then, yeah, it comes across as we see more physical symptoms, people coming in with chronic pain and things, and much more physical, which again goes back to exactly what we were saying with older people. It's that presentation is slightly different. So probably it is valid for us to say to people who see working age adults, actually, have you thought that this is a trauma presentation? And some of that stuff that we were talking about is very valid for that, probably that age group as well. And it's recognizing unresolved traumas, and we're probably not as good at that. And again, that's a bit of that can of worms. Do we really want to ask those questions? I'm not sure quite how we don't know how we're going to manage it if somebody comes across and says actually they've been through a traumatic war or abuse or something like that. I don't know if we always feel equipped to cope. But yeah, thank you, Sasha, that was really useful. Were there any other questions or observations that anybody had?
Nina just said, when we talk about old family members, trauma seems like too big a word to use, like trauma has to be something huge.
Yeah.
I think that's a really important point, actually, because... Oh, sorry, Nina, go on.
No, I was just going to say, I just find that, like, I guess my dad's maybe a bit too young for this demographic, I don't know, but even with my granddad, like, they've probably gone through traumatic things, but if you use the word trauma, they're like, no, like, I wasn't in a war, so I haven't really been through trauma. But then when you actually hear, again, like we're talking about generational trauma, some of the things that, you know, their parents went through, or even if, like, you know, for example, like addiction or something, it won't be, maybe even the language used is really important, because I think the trauma to them is like, oh, that's too much, too big of a thing, even though it is technically trauma.
Yeah,
I think you're right, Nina, and I think as professionals we're trying to learn that language, that actually traumatic events can lead to mental health problems post-on, but that's not a language that often, even as professionals, we don't always understand that. But I think you're right. If we use that, we may not capture everybody. So sometimes it's asking questions in multiple different ways to a language that works for people, and recognizing somebody who's 65 and 85 are quite different in their experiences and things. But I think you're right. We will all benchmark what we think trauma is from world history or lives and things that have happened in families.
I was just going to say as well, I do find it's quite common for older adults to downplay their symptoms. So what will often happen is they'll come for an assessment and they'll already have done their questionnaires, and their questionnaires won't be in caseness for depression or anxiety. They're very low. And when we meet them and actually speak to them and get more information, they're often actually, we would score them much higher. And I think there is often that thing of maybe downplaying or not recognizing the severity actually of what's going on for them. And just, again, it's just about normalizing what they're feeling and encouraging them to be open, which isn't always easy.
And I suppose I didn't sort of make that point probably enough when I talked about scales and using those kind of assessment tools are to help you. They are instead of professional judgment. So I've had younger people who will score right down the 5, everything in life is terrible, but actually that's not where it is. And I've had, as Rebecca says, people who score very low and actually it's worse. They're to help in that history taking. They're not you're something you do instead. And so that, just like professional judgment is the most important thing. And if people are telling you something that doesn't match up, think about why they might be doing that. And as again Rebecca says, it's sort of almost playing it down. And the other thing is, people don't want to think that you think it's that bad, and that they might be overplaying it because they've seen people who are worse. This all sounds a bit hopeless, but actually, do you know, I've got 2 people that will stick through my professional life forever. You know, I had one patient who was in Shipley Hospital, and we recognised the depression was playing a massive part of why he was in hospital and everything else. And for years later, he would come in at Christmas and visit to remind us and to remind himself that he got better. And actually, it took a lot of time. Okay, so it didn't happen quickly. And we were at the point where, you know, we were thinking of sort of ECT and things like this, but actually he got better. And it was a reminder that sometimes you need to spend a bit of time, but you can get there. And then the other one, when I was a GP, I had a picture on my wall of somebody again who came to see me. And he said that he remembers me saying, you know, you may be at the bottom of the well at the moment, but, you know, I'm here with a ladder to help you out. And he said, again, it took a long time, but he got there and he didn't relapse and he didn't go on to. So there are very positive stories, and you can make a real difference to people's lives. And I suppose as professionals, those are the ones. Now, Rebecca will probably have millions of them because she'll like this all the time. But I suppose just those times as a professional, you have those times when actually, and those are the stories and those experiences that you carry with you. But I'm sure you've got tons, Rebecca, of stuff that's really positive.
I was just thinking about, actually, when we're thinking about frailty, and it's really interesting because I think part of the training that we offered to our clinicians was what are our assumptions about older adults, and do we work with them differently? Are we a little bit more gentle when actually they maybe are quite more than capable of managing the more intensive treatment? And actually, I've worked with many older people who their emotional strength and ability and has been incredible, and they have worked so hard in therapy, and it's been difficult because I think a lot of them have realized, well, why have I waited till I got to 70 to do this? But at the same time, there's something so powerful about them. This is my time now, and there's a real strength there. Absolutely, there's strength for attending therapy. And yeah, don't always assume that people are emotionally frail, psychologically frail, just because they may look physically frail.
There's a question from Shona in the chat, which is I don't know if Shona wants to say it herself.
Yeah, I'm here. I was just saying that I come across a lot of older people that I suspect are neurodivergent, but of course they've never been diagnosed as such. And sometimes you find that traits and anxiety start appearing as they get older. And I'm just wondering if anybody is looking out for that.
Oh, that's a really complex one. I think where I would think in primary care is if I'm coming across a situation where medications and things aren't helping, and they've not responded to things like talking therapies. Those are the kind of people that I would probably refer into specialist services. Now, are specialist services looking for them? Ooh, I don't know. I think, again, they would be looking. That's probably, I don't know if there's anybody on from a specialist service that could help. I mean, Rebecca, is that something that you even would do, any of the sort of like ADHD assessment scales and things, or would that be beyond where you would be thinking of?
Yeah, so in our primary care service, we don't do any specific autism or ADHD specific treatment or support or scales. We, again, would just very much work with what the client brought. But I think as professionals, we may be, as the comment said, may be very much aware that this person possibly could be neurodiverse, and actually is our service the correct service? Would the BANDS service maybe be more appropriate? Would the services for older adult CMHT be able to offer something more intensive? But actually, if what that was causing was anxiety or depression, then actually we could absolutely work with that in primary care.
You'd be looking at working with the outcome of the expression.
Working with the symptoms of the anxiety.
Yeah. And for lots, and I think that's one of the things, isn't it, when people think about ADHD, not everything is about medication. Some of it is about how do we learn to and manage our lives with it.
Yeah.
And so the answer is that people will need a spectrum of support if they get to get a diagnosis anyway. But that's a great question, Shona.
Mm-hmm.
And I wish we had all the answers. But
absolutely,
yeah, be seeking support. If things don't get better, that's when you look at specialist services. Now we're drawing towards a close. Has anybody got any sort of burning things that they want to say? I'm just grateful that you've turned up to chat with us today.